Well, thank you very much. We know that American medicine is the best in the world, and people come from all over the world to take advantage of some of our sophisticated care. Uh, you mentioned social determinants of care, and that's very important because some of the things that, for instance, impact life expectancy have nothing to do with medicine. They have to do with the social determinants of care, what some people have called upstream medicine. Others, the Residence Review Committee and the ACGME call system-based practice. And these are things that impact on people's health, like a a poor person who doesn't have a safe place to walk, and there are no healthy places to buy food in their neighborhood. But we, the physicians that I speak to, really are the biggest patient advocate, and they are very distressed by the increased administrative burden. Now, we're, as the patient's advocate, physicians are interested in quality and safety and improving the patient experience, and certainly take responsibility every day for the care of their patients. But I'd like Stan to fill us in on how his company is making practice sustainable for both large and small healthcare organizations, and how he's making it possible for them to deal with the regulatory burden.
Thank you, Dr. Levien. So we see two stereotypes. One stereotype is more on the independent physician side. It's usually smaller organizations, 1 through maybe 9, 10 physicians, whether they're independent physicians or they're groups. But usually those type of organizations lack many resources. They lack the access and the regulatory knowledge and oversight. They lack the technology that's going to enable them to run reports and control their patient population. They usually lack corporate structure. And when I say corporate structure, that includes human resources as well as it includes documented policies and procedures. Giving you an example, the lack of having a chief medical officer or chief medical information officer, the lack of designated roles, the lack of quality assurance and quality control across the practice. So ultimately, they're stuck in the fee-for-service model. And therefore, they're kind of spinning their wheels. And I'm going to ask Dr. Erdik at some point to weigh in on where he's seeing the trends of the incentive payment system going, because from what we're seeing in the marketplace, 2021, we were looking at 7% downside and 7% upside and a multiple of 3 after. And 2022, we're looking at 9% downside, 9% upside, up to 27%, respectively. So, Dr. Erdik, if you were to say, which direction are we heading? And do you think that providers and systems can just close their eyes and focus on keep spinning their wheels and doing transactional medicine? Do you think that this is going to pass by, or do you think that this is here to stay?
Thank you, Stan. I mean, I think, in my opinion, this is becoming a either succeed or die, especially for small practices, right? Because ultimately, if you are the small fish in a big pond and then the fishermen are heading in one direction, you can't really escape that. And they hold the purse strings. So you can try to fight them as much as you want, but resistance is futile. So you're like a little hamster in a big spinning wheel. Unfortunately, that's the sad reality of it. So many providers are also not incentivized to align with these risk-based payments. So basically, ultimately, these HCOs, healthcare organizations, as well as all payers, should communicate, should is the emphasis on the word, because I don't think they really are, with the providers on how to change their workflows to align with these risk-based payments, right? So ultimately these risk-based payments require high-value care delivery for maximum reimbursement. It's not just that you spend 20 minutes with the patient, it's that what's the afterwards? Are they really taking their medication? There's a lot of follow-up. And as Dr. Levien has said, with regards, a lot of this will sort of turn into a lot of administrative overhead costs and stuff. And in order for you to recoup that, you need to have a game plan and you need to know who is in charge of doing what. And you need to be able to use the sort of most cost-effective employee to do the most cost-effective thing, right? So you can maybe hire a front desk secretary for $15 an hour, and she can probably have a list of local parks that patients can walk in. Okay, but from a chronic care management, is that front desk secretary really the best person to call patients daily to ensure they're taking their insulin or to ensure they're taking their medication? So this all needs to be delegated. And Stan, as you said, the bigger the fish in the pond, I mean, it's easier, right? If you're, I don't know, Kaiser Permanente, I can guarantee you have a whole department dedicated to providing this sort of things, and then you have $200 billion budget to do whatever you want with it. And you can adjust your EHR so that even though you're not necessarily meeting all the goals, you're picking and plucking all the goals that you are meeting and reporting those.
So true, but to be honest with you, what we see is not always the case. So what we do see is even bigger infrastructures and healthcare organizations are having often poor performance, poor clinical performance, and have hard time implementing because they are so big and because the infrastructure is giant, and it's often, even though within the big infrastructure, there's islands of information, and they are having hard time implementing across the board. They don't have a consolidated ability to look at all their data. So you look at their diabetic performance, and they might have 1 or 2 stars across their patient population, and their goal is to get to 3 or 4. And it's something that they're not able to get across because they're also spread out and they're one big, huge machine that has a hard time maneuvering. So what would you say would be a best strategy for healthcare organizations that are sizable but having hard time to implement? How should they go about being compliant, selecting their quality measures, and ultimately getting on the road here of achieving their targets, selecting their targets, and achieving their targets for 2022?
I see your point of view. It's almost like you get a flat tire. What do? You call AAA, you get roadside assistance, they change the tire, you're on the road, right? Let's say a MARTA bus, or a SEPTA bus, or whatever your local transportation company's bus gets a flat tire. What do? Can they call AAA? Not necessarily. And then it's going to be more bureaucratic. So bigger it is, the more bureaucratic it is. So to answer your question, I don't think there's going to be a one size fits all. I think it'll boil down to the particulars of that healthcare organization, especially with regards to what their leadership style and organizational culture is. But all in all, I would say there needs to be one person that is driving the change, right? They need to designate one person that does it. And in my opinion, the key to all of this boils down to chronic care management. So if you sort out your chronic care management issues with a single person, I think the rest of it will just come through just following. Because if someone takes charge and start leading the effort, it's easy for people to join even without knowing. If you've ever heard of the analogy, the bus to Abilene, no one knows why they're on it, but it's still going to Abilene. So if you're going to a more less fee for service, more value based, as you get more people on the bus, the more these islands of primary care providers under the big umbrella, and everything will be more aligned to get on it. But all in all, to answer your question in the most simplest terms, I think it'll boil down to just chronic care management.